Yes, sir. Today we have an open house. Good morning, everyone. Today we have open house regarding the pancreatic ductal adenocarcinoma, more on the carcinoma head of pancreas. And today our special guest is Dr. Diksha Kapoor. She is a senior consultant at BLK Max Hospital. So we can start discussion regarding, sir. First, whenever the resident will ask the question, first we can start our discussion.
Yeah,
Yeah.
so I will start. Good morning, Diksha. Thank you for joining us once
Sir,
again.
good morning, sir. Good morning.
So, first question, which I think there is confusion in the textbooks and literature also, that what is pancreatic ductal adenocarcinoma, that is head pancreas cancer, and what are periampullary cancers?
So, sir, I think this is a very important question. Most importantly, because it makes a difference in the prognosis of the patients and how they behave in the long term. Periampullary cancers are those cancers which originate within 2 centimeters of the uh, ampulla of Vater and involve the ampulla of Vater. So they can be from the duodenum, they can be from the common bile duct, or from the pancreas. But PDAC, pancreatic ductal adenocarcinoma, is a pancreatic cancer which is anything and everything apart from that. There is a difference in the way these
So
tumors
sometimes
present.
students, yeah,
There's a difference.
students are sometimes confused that is it 1 centimeter around ampulla or 2 centimeter around ampulla?
So please correct me if I'm wrong, but I think it's 2 centimeters around the ampulla.
Yes, yes. I think most texts would mention 2 centimeter around the ampulla. So, and as Dr. Diksha said, that you have to be clear that ampulla is the common channel formed by the lower end of the common bile duct and the terminal part of the pancreatic duct. It is called ampulla because it is little more dilated, like ampulla of the rectum, and then it opens in the duodenum at the papilla, which is the nipple-like projection in the second part of duodenum on its medial wall. So periampullary cancers, as she said, would include cancers of the ampulla, lower end of the common bile duct, cancer at the papilla, and peripapillary duodenal cancer also. So D1 and D3 cancer will not be periampullary, but if there are tumor in the duodenum is around the papilla within 2 centimeter, then it will be periampullary. And the most important point she mentioned is the prognosis in terms of prognosis. So, Diksha, from the management point of view, how and why is it important for us to differentiate between the two?
So first is the clinical presentation. Periampullary cancers will usually present with either jaundice or bleeding from the duodenal mucosa if it's a duodenal tumor. Uh, they are usually detected earlier compared to a pure PDAC, which can cause jaundice a little later in the progressive disease. Once the tumor in the pancreatic head grows and starts impinging on the ampulla of Vater and the common bile duct. But typically in a lower end CBD tumor, the jaundice will come early. And in a duodenal tumor, there will be oozing or bleeding from the duodenal mucosa, obstruction of the ampulla, again causing jaundice. And typically this has a waxing and waning pattern. Typically, I think is a wrong word in about 1/3 of the cases, because the mucosa will slough off or the tumor will slough off. At that time, the jaundice will resolve a little bit, only for it to come back again. Since these tumors are detected early, their prognosis tends to be good. PDAC is typically detected a little later in the progress of the disease, which is not a periampullary tumor. The prognosis tends to be worse. The other important thing being that at the ampulla of Vater, there are 3 different epithelia which are meeting. The intestinal epithelium has better prognosis than the pancreatobiliary. So if the periampullary tumor is of the intestinal epithelial type, the prognosis is like that of a duodenal carcinoma. But if it's of the pancreaticobiliary type, it's more like that of a PDAC. So in considering these things,
So, students again, yeah,
so considering these things,
yeah,
the
please carry on. Please carry on.
the kind of surgery we'll perform, how extensive we are going to be in the operation, in two main areas. One is the clearance of the uncinate, and the other is how high we end up going on the bile duct margin. These two things are the most important things that a surgeon should correlate during surgery with respect to this. Followed by that, the uh, kind and the type of chemotherapy that needs to be instituted after the surgery is complete and the surgical recovery has happened. The other thing that the surgeon needs to be aware of, that typically the surgery for a periampullary cancer will be easier, but the chances of post-operative complications will be higher because the pancreas is soft. Very often, if it's a duodenal tumor or a small ampullary tumor, the pancreatic duct may not be that dilated. Plus, the fibrosis of a PDAC will be less in a periampullary than a PDAC versus a surgery for pancreatic head cancer. The surgery will be more difficult, but the post-op recovery tends to be better because the PJ is easier. The pancreas tissue is firmer, it's more hard, and the duct is typically more dilated. This is not an exclusive criteria, but this is a common observation.
Yeah, so few very important points which Dr. Diksha has made, that in periampullary cancer, because the tumor is either in the lower end CBD or in the ampulla or at the papilla, very early the patients develop and present with jaundice. Except a duodenal carcinoma, a peripapillary duodenal carcinoma, where jaundice may not be present, it may be more GI bleed in the form of blood loss or even frank gastric outlet obstruction. On the other hand, pancreatic head cancer, the patients would present with other symptoms like pain, anorexia, and weight loss, and then jaundice. Also, I think biologically they are different. Pancreatic ductal adenocarcinoma biologically has a worse outcome as compared to the periampullary cancers, and there also, as she said, the intestinal ones have a slightly better outcome. The third important thing she mentioned is in terms of the ease and difficulty of resection. Periampullary cancers, because the tumor is small, there is no peritumoral desmoplastic or peripancreatic desmoplastic reaction. The planes are easy. So resection part of the PD is easier, but because the gland is soft, and in case of a lower end cholangiocarcinoma or in case of a peripapillary duodenal carcinoma, the pancreatic duct is not dilated, and these are the two most important factors for a PJ leak. The complications are more. Reconstruction is difficult. On the other hand, in pancreatic ductal adenocarcinoma, especially if there is a reasonable sized tumor, the PD will always be dilated, and because of the peritumoral desmoplastic reaction, the gland is firm. So these are two favorable factors for the pancreatic anastomosis, and the leak rates may be lower. More so if you have a pancreatic ductal adenocarcinoma on the background of chronic pancreatitis. Then the gland is even more firm, the duct is dilated. So reconstruction, especially the PG anastomosis, is technically easy. Sutures hold well. Chances of leak are less. Even if leak occurs, because of low enzymatic secretion in the pancreatic juice, the consequences of leak are not as disastrous as they would be in a normal gland. So as Dr. H. Ramesh, who probably has our country's largest experience dealing with chronic pancreatitis and pancreatic cancer, always says that in chronic pancreatitis and in chronic pancreatitis with pancreatic cancer, the resection is difficult, but the reconstruction is easier. Okay, so Diksha, now we know that these are the important reasons why we should try to differentiate between them, other than the clinical picture, because clinical picture at some stage will be common to all these periampullary cancers and pancreatic ductal adenocarcinoma in the head. How investigations can help us to Or before we move on to that, would you like to say a few words about body and tail PDAC and uncinate process tumors, the peculiar features which they have in terms of clinical presentation?
So, I think because of all of these factors, sir, pancreas has gained the notorious, infamous image that it has, because a good two-thirds of the tumors are detected very late. Both pancreatic body and tail tumors and uncinate tumors are detected late in the course of their disease. Body and tail tumors don't have any structure surrounding them on which they can cause compression early on and lead to an early diagnosis of the disease. Typically, the patients will have some amount of upper abdominal or back pain, weight loss or anorexia, worsening of diabetes, etc. The tumors tend to become large. They tend to infiltrate the posterior part of the peritoneum or the retroperitoneum or the renal fascia, the greater vessels, the superior mesenteric vein and the artery come down to the DJ flexure before they present with a symptom that the patient will worry about and come to the hospital. On retrospective history, you may find that there are a lot of telltale signs which will say, yeah, that this could have been because of the tumor 6 months, 8 months back. That's about the body tail tumors. So they tend to present later. They are usually larger. Um, we tend to operate on them because the vascular involvement is not as sinister looking as it would be in a pancreatic head tumor. But then there is more than enough evidence now that early chemotherapy followed by surgery may have some value in bigger tumors and in those where CA 99 is on the higher side. The uncinate process tumors are notorious for early involvement of the superior mesenteric artery and then the vein. So, because the uncinate wraps itself around the artery and the vein like a claw, tumors originating over there will have early vascular involvement but late presentation because they will have to grow upwards towards the ampulla of Vater before they can cause jaundice or any amount of gastric outlet obstruction. So that's about these two tumors.
So again, very important points that body and tail tumors have very non-specific symptoms. Patient will have pain, epigastric or even left hypochondrium pain, radiating or boring into the back, anorexia, weight loss, recent onset diabetes or worsening of diabetes. So if you have a middle-aged or elderly gentleman who has these non-specific symptoms, you have to think of CA body and tail of pancreas. Of course, there are other possibilities, but the other organs like stomach and colon, they will have GI related symptoms. Patients may have bleed, GI bleed. You have to keep the possibility of an HCC in mind in such a situation. Uh, Spleen, fortunately, doesn't is not a common site for primary malignancies. So, in an elderly gentleman who presents with features which are suggestive of a malignancy, you have to keep body and tail tumors in mind. And as Dr. Diksha said, these tumors, the resectability rates are even less than head of the pancreas because of important structures which can get involved, including the celiac axis also. Similarly, uncinate process tumors, because the common bile duct is more cranial to the uncinate process. There is no obstruction of the CBD, there is no jaundice. And these patients will again have very non-specific symptoms. But at the same time, even a small tumor in the uncinate process can infiltrate the vessels, the SMV and SMA, very early because the uncinate, as she said, goes behind these vessels and even wraps around it. So the resectability rates of uncinate tumors are low. In fact, if you have a patient where there is a mass in the head of the pancreas, there is no jaundice, but there is some there are some features to suggest GI bleed or even gastric outlet obstruction. You have to think of uncinate tumor in mind because it may have involved a D2, D3 genu or even D3, but not the CBD. And again, in these patients, the PD may not be dilated till the tumor has gone into the middle of the head of the pancreas and obstructed the pancreatic duct. So these are two tumors which have peculiar features, and you have to keep them in mind. So periampullary cancers are in the head and duodenum region. whereas PDAC, majority are in the head, but they can be in the uncinate, they can be in the body and tail of pancreas. So, Diksha, the next question is that how does imaging help us to differentiate between these, especially the periampullary and pancreatic head cancer? And whenever we make, obviously, ultrasound will be done. So, once ultrasound suggests that it can be a periampullary or a pancreatic cancer, what should be the next investigation?
So let's first talk about the ultrasound, sir. Having assumed that there are no obvious liver mets, ascites, or anything that would be sinister looking on an ultrasound, let's talk about the primary tumor. So for a periampullary, there will typically be some amount of bile duct dilatation, and if it's a good proper timing of the scan and a good ultrasonologist, they will be able to comment on the status of the pancreas and the dilatation of the pancreatic duct. Similarly, for the pancreatic head tumor, they may or may not be able to see on the scan whether there is a tumor in the pancreatic head or not, but they should be able to comment on these two features. The imaging modality of choice is pancreatic protocol CT in both cases, uh, where the disease gets an opportunity to define itself in totality, and the IV contrast is given in such a way that we can assess the differential enhancement of the pancreatic parenchyma with respect to the tumor. So usually a large periampullary and a pancreatic head cancer may be difficult to differentiate between. But if it's a small periampullary carcinoma, it may be difficult to see the tumor also on the CT scan. What typically will be seen is a dilated bile duct and a dilated pancreatic duct. And there will be a double duct sign where the radiologist will say that there seems to be an abrupt cutoff of both of these entities. In that case, if the suspicion is high, then the next test becomes a side viewing endoscopy to assess the ampulla and then try and taking a biopsy from there. But a pancreatic head tumor will be seen as there will be differential enhancement compared to pancreatic parenchyma in the pancreatic head, where it is usually more black looking than the rest of the pancreas in a pancreatic phase of the pancreas protocol CT. So these are hypodense lesions, less vascularity. Uh, Depending on the location from where they are arising, they have a tendency to cut off the pancreatic duct, the main pancreatic duct. And that will decide as to where there is dilatation of the pancreatic duct or the bile duct. So you want to add anything?
Very important that once on ultrasound you suspect that, sorry, you were saying something?
No, sir. I was just asking if you wanted to add anything to that.
Yeah. So if ultrasound is suggestive of a periampullary or pancreatic head cancer, which would be that you see intrahepatic biliary radical dilatation, CBD is dilated, and CBD is dilated in its entire extent up to the lower end, as opposed to a hilar cholangio or a gallbladder cancer, where you would not see the CBD in the entire extent. And at the same time, you may see a dilated pancreatic duct also. So that becomes a strong suspicion on ultrasound of a periampullary or a pancreatic head cancer. As we discussed earlier, if it is a lower end cholangio, only the CBD will be dilated, PD will not be dilated. You may see, if on a good ultrasound, you may see thickening of the wall of the CBD. You may see an intraluminal polypoidal mass inside the dilated CBD, if it is a polypoidal type of a lower end cholangiocarcinoma. And if the tumor is of a significant size, you may see a mass lesion. On the other hand, a peripapillary duodenal carcinoma may not cause CBD dilatation, may not cause PD dilatation, but then the picture is more duodenal with GI bleed and maybe gastric outlet obstruction. So once ultrasound makes a suspicion, as she mentioned, the investigation of choice is a pancreatic protocol CT scan. The key features of a pancreatic protocol CT scan are that you have to inject a large volume of contrast. Check with your radiology friends. I think it is about 150 ml. And speed, very high speed, about 3 to 5 ml per second. So that cannot be done manually. It has to be done with an infusion pump. And then you take images after, of course, you have obtained a plain CT before injecting contrast. After injecting contrast, you take an early arterial phase, a late arterial or a pancreatic parenchymal phase, then a portal venous phase, and a delayed phase. The timings are about 20 to 40, 40 to 60 and all. Again, check with your radiology friends. The early arterial phase is important. As she said, that the pancreatic parenchymal phase is the late arterial phase. That is where PDAC will be seen as a hypodense lesion. So rest of the pancreas is enhancing, but the tumor is not enhancing because there is a lot of desmoplasia, a lot of fibrosis in this tumor. So why do we take early arterial phase? Early arterial phase is to rule out a neuroendocrine tumor, because it is in that phase that a neuroendocrine tumor will shine very brightly. It is a very brightly enhancing lesion. But for the PDAC, it is the late arterial or the pancreatic parenchymal phase. And then, of course, you look at the vessels and you look at nodes and liver. Uh, Now, Diksha, Dr. Ved Prakash wants to know, okay, let us deviate into this, that what is groove pancreatitis and how do we differentiate? And maybe you can touch on the other uncommon differential diagnosis, which is autoimmune pancreatitis. Now, students, both of these, groove pancreatitis and autoimmune pancreatitis, you should not make a clinical or even a radiological diagnosis. These are all histological surprises. It will be very rarely that based on imaging, you will be able to make the diagnosis of a groove or an autoimmune, which Dr. Diksha will tell us.
So let's first talk about groove pancreatitis. So groove pancreatitis is one of the forms of chronic pancreatitis. Again, the history typically will be long. The two common symptoms the patients have got is pain and some amount of gastric outlet obstruction because involvement of the pancreaticoduodenal groove. On the CT scan, there will be visible thickening in that area. There will be thickening of the duodenal mucosa. There will be some amount of gastric outlet obstruction. There will be thickening in that part of the pancreas which lies in the pancreaticoduodenal groove, with or without changes in the rest of the pancreatic parenchyma, with dilatation of the duct. So yes, this can look like a PDAC, but a good radiologist will be able to tell you that this is more like the fibrosis of chronic pancreatitis than a well-formed pancreatic ductal adenocarcinoma. Now, again, like everything else in pancreas, these two are not mutually exclusive. So one cannot say that if this looks like groove pancreatitis, this cannot be PDAC. And if this is PDAC, there cannot be a background of pancreatitis or chronic pancreatitis in the background. Then the best next thing to do is to try and take a tissue sample from there. In which case the findings are typically that of groove pancreatitis with more of chronic inflammatory changes and less of and no neoplastic components or atypical cells seen in this area. The biopsy is better done if it is EUS guided, where the endoscopist will be able to tell on a well performed endo ultrasound the features of the lesion which are seen in the pancreaticoduodenal groove. Depending on which is the most worrisome area or the most hypo-intense area on the endoscope, the endosonologist will try and target that area for a biopsy because that area has got the maximum suspicion of malignancy. Again, even in a lot of cases, if the biopsy is negative, but clinically and radiologically, the clinical suspicion of pancreatic ductal adenocarcinoma is high, one should err on the side of planning a treatment as per PDAC rather than saying that this biopsy has shown chronic inflammatory reaction and this cannot be PDAC. So it's more a clinical judgment which goes in favor of what we are going to do rather than exclusion of any of the tests per se. Sir, on this, if we can finish first groove pancreatitis, we'll go on to autoimmune.
Yeah, just a few points that, as Dr. Diksha mentioned, there are some subtle features which may suggest you that this is more likely to be groove pancreatitis rather than PDAC. Although, as she said, in majority of cases, it will be very difficult. In fact, you should know that larger number of groove pancreatitis are retrospective diagnosis. Either you manage the patient conservatively or you operated and you didn't find PDAC. But there are some subtle features. As she mentioned, gastric outlet obstruction is more common as opposed to jaundice. Now, groove pancreatitis is the groove between the cranial half of the head of the pancreas, the CBD lower end, and the proximal part of the second part of duodenum. So the groove there between these three structures, if there is inflammation, that is called groove pancreatitis. So gastric outlet obstruction features are more common than surgical obstructive jaundice. And then if you carefully look at the CT or the MR, in that triangle between the proximal half of the suprapapillary part of second part of duodenum, the lower end of CBD, and the cranial half of the head of pancreas, you will find inflammatory edema rather than a mass in the head of the pancreas. So, as she said, a good radiologist can at least raise a suspicion that this is likely to be groove pancreatitis. And then, of course, you combine with maybe other investigations like MR, you do a side viewing endoscopy where you may see some inflammatory edema which is confined to the medial wall of the proximal half, the suprapapillary part of the second part of duodenum. You don't see any ulceration or nodularity or infiltration of the duodenal wall. You can do an EUS, which again will show inflammatory edema rather than head a mass in the head of the pancreas. And you can do FNAC, EUS guided, which will only show inflammatory cells. But then, as we know, any biopsy cannot rule out malignancy. It can only confirm malignancy. If you see positive cells, you say it is malignant. But if you don't see any malignant cells, you can't say it is malignancy. So it's a combination of clinical, radiological, maybe tumor markers, the side viewing endoscopy, EUS finding, FNAC, that you make a judgment. As she said, if you cannot rule out PDAC, it is better that you treat it like PDAC. Of course, after counseling the patient, that it may turn out to be benign. Autoimmune, Diksha?
Yes, sir. So just before that, irrespective of whether we have a preoperative biopsy or not, there is still a chance that 5 to 10% patients who undergo a Whipple may have a negative report for malignancy. I think routinely it's very important to counsel them that there is a possibility, and it should come as a pleasant surprise to the doctor and to the patient. I think this is a very important part of a Whipple counseling to be done by the surgeon for the patient, because it should not be a surprise later on कि अरे tumor नहीं आया but I underwent such a big surgery. So I think this is a very important thing. Now coming to autoimmune pancreatitis. So autoimmune pancreatitis, the presentation will be different than it is that for a PDAC. Usually it will be a fifth to sixth decade male with predominant jaundice, with some amount of pain, but the weight loss component is less compared to that of a PDAC. And the appearance of the gland is very different. It's a segmental thickening of the pancreas, or an sausage shaped pancreas in which the duct is not dilated. In an autoimmune pancreatitis, typically the duct of the pancreas is normal looking, the rest of the gland is swollen, and there is typically an enhancing halo in the periphery of the pancreas, and therefore the sausage shaped appearance. Again, the radiologist on this account should be able to raise a suspicion that this looks more like an autoimmune pancreatitis than a pancreatic ductal adenocarcinoma, although the appearance may be diffuse or it may be segmental. Meaning that it may involve just a part of the pancreas and not the entire pancreas. The additional tests will be IgG levels in the blood, and again an EOS guided biopsy of the worrisome area, and then which has a tendency to show a lymphocytic infiltration on the biopsy. So you can take over
And
from
the,
here.
yeah, and the management?
Management in autoimmune pancreatitis would be steroids. So here again, it is a clinical judgment. If there is a doubt of a malignancy, that needs to be explained very clearly, and the management should focus on malignancy if the doubt goes that way. Because if we end up giving an inadvertent steroid course in a PDAC, that will just worsen the extent of disease.
Yeah. So important points that clinical presentation may be same as chronic pancreatitis or pancreatic ductal adenocarcinoma, but the radiological finding, the imaging findings are quite characteristic. The pancreatic duct is not dilated. The gland is bulky, swollen, uniformly enhancing. More commonly, the entire gland is looking like a sausage. Now, all of you who are vegetarian may not eat sausage, but you should at least have a look at the sausage, how it looks like. And as she said, sometimes it can be focal segmental also, where it has to be differentiated from a pancreatic ductal adenocarcinoma. But as we mentioned earlier, PDAC is hypodense. So it appears slightly grayish as compared to rest of the parenchyma, which is enhancing in the pancreatic parenchymal phase. Whereas in autoimmune pancreatitis, the entire gland will be enhancing and bulky, smooth in outline, no dilatation of the pancreatic duct. And we have two investigations which can help us to diagnose autoimmune once you suspect it on radiology. One is IG4 level, and second is an EUS guided FNAC, which show infiltration with lymphocytes. So once you have a radiological or histological, cytological suspicion, then there is no harm in giving a therapeutic trial, because if you give steroids within 4 weeks, when you repeat the imaging, you will should see resolution of the imaging findings. So that again becomes a kind of indirect confirmation that your diagnosis was autoimmune pancreatitis. But again, both these entities, groove and autoimmune pancreatitis, as Dr. Diksha also said, they more often come as a histological surprise rather than a preoperative diagnosis. And the point about counseling is very, very important, because as we have discussed earlier in these classes, the dictum is that you try to make every possible effort, depending on what equipment, what expertise you have, how much is the cost, how much is the affordability of the patient, to try to get a tissue diagnosis. But it is not mandatory. It is not that you will operate only when you get a positive tissue diagnosis. You can operate without a positive tissue diagnosis also, based on strong clinical and imaging suspicion. But if you are operating without a tissue diagnosis, it's very, very important to inform and to document that, as she said, in about 5 to 10% of cases, the final histology may not show malignancy. Now, that is all right if the patient does well. The problem comes if, unfortunately, there is a major morbidity or the patient dies and the histology shows no malignancy. Because then everybody will pounce upon you and say, why did you operate when there was no malignancy? They don't know, they don't accept all these arguments which we make in our discussions, that it is very difficult to prove the diagnosis. So it's very important to have good counseling and good informed consent, detailed informed consent, mentioning that there is a small possibility that the final diagnosis may not be malignancy. You should also tell and document the patient that, look, the only other option is that we wait. But waiting will not help, because the symptoms will remain. There will be no way that you can prove or disprove the diagnosis. And if you wait long, the disease may become unresectable. So you have to explain all these things to the patient and uh, document it also for your own defense. Okay, now since Anand, in between you want to say or ask anything, please feel free to chip in.
Yes, sir.
Students,
Yes, sir.
raise your hand or type your question in the chat, whatever you want to ask from Dr. Diksha. So, Diksha, what findings on CT, especially for pancreatic? Because as far as periampullary cancers are concerned, locally they are almost never unresectable, because they are not infiltrating any structure. The only reason a periampullary would be unresectable is a metastasis. So let us leave that. For pancreatic ductal adenocarcinoma, what are the important things that we are looking at in the CT to say whether it is resectable, borderline resectable, locally advanced, and of course, metastatic?
So, sir, I've always requested all students to look at the CT from outside inwards. So always look at the area of metastasis, the liver, the omentum, and ascites, and any other area where you think there can be a metastatic deposit, which will make the stage 4. Somebody who has the mic on, I would request them to please mute it. Hello.
Yes.
Yeah. So always go outside inwards. So having ruled out stage 4 disease, let's come to the primary. So the primary is the size of the tumor, and then we start looking at the involvement of the bile duct, the duodenum, the pancreatic head, of course, and then we go to the vasculature. Sorry, yeah, and then we go to the vasculature. So the vasculature for a pancreatic head tumor, the most important being the superior mesenteric vein and the superior mesenteric artery. Along with the superior mesenteric vein, we need to look at what circumference of the vein is involved. That is, the tumor contact to the vein is for what circumference? Is it 90, 180, more than 180, or is it complete encasement? What is the length in which it is involved? Is it a suprasplenic or a portal vein involvement, or is it an infrasplenic or an SMV involvement? Along with this, while we are looking at the venous anatomy, I will request that anybody who's sitting in front of the console simultaneously requests the radiologist to convert this into a 3D vascular image, and we start looking at the smaller veins, that being the gastrocolic trunk, and that same area, the middle colic vein, and then lower down the inferior pancreaticoduodenal vein, the ileocolic vein, so that the venous assessment gets done in one shot. The next, let's come to the arteries. So we want to look at the superior mesenteric artery. Again, if it is no contact, 180 or more than 180. While we are looking at the SMA, we must look at the IPDA or the inferior pancreaticoduodenal artery. Along with this, try and assess the anatomy of this with the first jejunal vein and the middle colic vein, because these are very important landmarks during surgery. The first vein that a surgeon will encounter is the gastrocolic trunk, followed by the duo of the first jejunal vein and the IPDA. Depending on what step of uncinate you are at, one of these will come in a difference of 5 to 10 minutes of resection. Going down, if there is SMA involvement, how lower down and how much to the left is it going? If is the origin of the middle colic artery also involved? And if there is an uncinate mass, is the SMA involved lower down to involve the jejunal arteries, the second jejunal artery or the first jejunal artery trunk or the ileocolic trunk? Moving upwards, so this is superior mesenteric artery becomes one axis. The other axis being the celiac axis, we need to look at also the involvement upwards. So whether the tumor involves the GDA, the common hepatic artery, the hepatic artery proper, or if there is infiltration moving upwards to the bifurcation of right hepatic and left hepatic. It's very unlikely that a tumor that is that extensive and involves everything will be resectable, but we must look for anomalies. At least 30% of these patients will have an associated arterial anomaly in which an aberrant right hepatic may be coming from the SMA, or there may be an early bifurcation of the right hepatic, and although the tumor is small, but the artery loops down and then goes up. There, where it comes to vascular anatomy, I feel that in today's day and age and today's availability of CT scans, this should not be a surprise on table. We should also look for any amount of celiac axis stenosis, so that if that is there and the GDA is enlarged and the collaterals in the pancreatic head are open, then the surgical planning changes as to how we will do the operation if celiac axis is stenosed. So I think all of this needs to be seen by the surgeon themselves on the CT console in the steps that they would operate. I think that's the best way to assess a pancreas CT.
So I have a few questions which I'll come later, but Dr. Jasmeet wants to know that now there are some reports that even if the tumor is resectable, it is not borderline resectable, it is clearly resectable. Is there a role of neoadjuvant treatment to mainly to assess the tumor biology? And he wants to know that is it being done in some centers in the country?
There is no yes or no answer to this, sir. Dr. Jasmeet, there is no yes or no answer to this. When you're talking about resectable PDAC, unfortunately, right now the discussion limits itself only to anatomical resectability. When we are talking about the resectable definition, we are not including the biological markers like CA99 levels, the size of the tumor, and the amount of weight loss or pain or the physiological status of the patient that has been there. So, if the tumor is large, if the CA19 is high, now these are very ambiguous words and there is no clear-cut definition. And if the surgeon feels that there are nodes around it and a neoadjuvant therapy will help in better case selection, yes, neoadjuvant therapy can be used for a typically resectable tumor. That means it's away from the artery and the vein. But if you want to say pure resectable in a yes or no answer, no, neoadjuvant has not yet become the standard of care. But this question, when you say resectable, implies that you're talking only about anatomical resectability. Now, there is a concept of biological resectability. Like I said, that's elevated CA99, big tumors, large nodal masses, associated pain, weight loss, etc., which will make this biologically borderline. I hope I've answered that
Yeah.
question.
So Jasmeet and other students, the answer which probably most examiners will accept in the exam is that as of today, if it is a technically resectable pancreatic ductal adenocarcinoma, you have to offer upfront surgery. At the same time, to show that you are reading recent literature, you can say there are reports coming in of use of neoadjuvant chemotherapy, even in resectable PDAC, with various aims, as we know of neoadjuvant chemotherapy. And you should also say that the concept of borderline resectability today is not only confined to anatomical borderline resectability, which is involvement of the vessels, but there is an ABC classification of borderline resectability. A is anatomy, B is biology. As Dr. Diksha said, CA99 level, most groups would say more than 500. PET scan, Dr. Anand wants to know, we'll come back to that. And size of the tumor, the severity of pain, the degree of weight loss, these are all indicators of biology of, and if you have done a biopsy for whatever reason and it is positive, then the pathological features. C is the conditional assessment. Conditional is patient's nutritional and performance status. So if the patient has poor performance or nutritional status, if the biology of the tumor appears to be aggressive, then even in the absence of the anatomical features of borderline resectability, you may use neoadjuvant chemotherapy. And as you yourself mentioned, many people are now using neoadjuvant treatment in pancreatic and even biliary cancers, which are aggressive cancers, to see the biology of the tumor. Because if in spite of neoadjuvant treatment, the tumor progresses, it indicates a very poor outcome. So even if you do resection, the outcome will be poor. But again, if you are using neoadjuvant treatment in a resectable lesion, the counseling and consent process has to be very, very meticulous. Because tomorrow, if the disease progresses, the patient may come back to you and ask you, doctor, at that time it was resectable, you didn't resect it, and now it has become unresectable, it is your fault. So you have to make sure that you explain everything very well to the patient and the patient understands it very well. But as she said, standard of care for resectable PDAC, if the patient is fit for PD, is upfront surgery. Now, Diksha Anand wants to know, we missed that point, that What should the students say in the exam when they are asked, would you do a PET scan? If CT scan shows a resectable pancreatic ductal adenocarcinoma with no distant metastasis.
So, I think the students are better off saying that there is no routine role of offering a PET scan if a CT scan shows a resectable disease, and there are no other radiological, biological, or physiological markers to suggest aggressive disease or a poor patient physiology. But at the same time, if the patient is an elderly patient, if we are considering surgery in an elderly patient, or if there are multiple systemic disorders, if the CA99 is elevated, and if there is any kind of ambiguity when we look at the tumor as per the classification, whether this is a truly borderline or a resectable disease, because resectable still means a 180-degree SMV abutment up to 180. In that case, the surgeon can offer a PET scan to the patient. In that case, the intention should be to look for things that will actually change my decision of offering upfront surgery, especially if the patient is elderly, has multiple comorbidities, or the tumor appears not so conducive to upfront surgery for whatever reason. In that case, I think it would be better to get a PET scan. You will be more justified to get a PET scan than offer upfront surgery.
Yeah. So again, what probably most examiners will accept is that, as she started by saying, that there is no role and place for a routine PET scan in every patient with pancreatic ductal adenocarcinoma. It may be used selectively, and selectively, again, you use the same parameters as we discussed earlier, which indicate more aggressive biology of the tumor, which is severe pain, which is significant weight loss, which is size of the tumor, which is CA99 level. If you've done a biopsy, then the pathological features, the grade, lymphovascular, perineural invasion. If there are bulky nodes, if it is borderline resectable and you are anticipating a vascular resection because you would not like to do a major surgery in the form of PD with vascular resection if there are distant metastases. So, and as she said, if it is an elderly patient, poor risk patient where chances of major morbidity and mortality are higher, you don't want to do that if it is not going to help. So, to rule out distant disease in select situations, you should mention, and you should probably do a PET scan so that when you are doing a PD or a PD with vascular resection, it is going to end up as an R0 and not that there are distant metastases and still you have done. Diksha, related to this also is the issue of the para-aortic or aortocaval nodes. Now, in gallbladder, most of us would not resect if these nodes are positive, although, as we discussed in one of the sessions earlier, the concept of oligometastasis is coming, but we'll not touch on that. What about pancreatic ductal adenocarcinoma? If you see a large aortocaval node, would you try to target that? How would you do that? And if it is positive, what would you do?
So, if again, this has to be in condition to whatever we are seeing with respect to the primary tumor. If the lymph node mets are large and the primary tumor is smaller, I would consider getting a targeted biopsy. And then, if it is positive, I would personally want to give chemotherapy, then take the patient up for surgery. And if the nodes are seen but they are not that large, I can take a call and then move forward with resection. There is an impact of para-aortic lymph nodes with respect to prognosis, but I think that is again more true for this gallbladder cancer and for periampullary cancers rather than for PDACs.
No. So suppose on CT scan you see a more than a centimeter round node with some hypodensity in the center suggesting necrosis. Would you like to target it using an endoscopic ultrasound for FNAC before you operate?
No, sir, not always.
I may probably have a different opinion that if I am strongly suspicious And if I'm sure that it is a true aortocaval node, not a retropancreatic node. See, in a thin-built patient, a retropancreatic node may look like an aortocaval node, but retropancreatic node is a regional node. Aortocaval, some people may consider as a distant node. So aortocaval node positivity, whether on endoscopic ultrasound or at staging laparoscopy or at laparotomy, if it is positive, it definitely indicates a poorer outcome. But then, as she said, if the primary tumor is technically resectable, you may still go and resect it. Of course, the outcome probably will be poorer as compared to a patient who does not have an aortocaval node. Would you agree with that?
Yes, sir. I totally agree with what you're saying. But if the question is that I would like to sample it, if the radiology suggests that it looks like a metastatic node, and the primary also is somewhat big with surrounding lymph nodes with a high CA99, I think I wouldn't sample it, but I would go towards a 4-cycle neoadjuvant therapy with appropriate counseling and then surgery. But if the primary is rather small and does not warrant neoadjuvant, but the lymph nodal mass in the para-aortic region looks big and does not correlate with the primary, that's when I would like to biopsy it to make sure that I'm not missing out on a metastatic deposit. And then take a guided judgment depending on the biopsy findings. That's what I meant, sir.
So that brings us to the okay. Let us take Dr. Ved Prakash's question because we have only 3 minutes left. So he wants to know: is it standard or reasonable to give neoadjuvant radiotherapy? He now wants to know radiotherapy in high risk cases for POPF. He says, as mentioned in PRIOPANC and FibroPANC trial. What is the role of neoadjuvant radiotherapy?
So, neoadjuvant radiotherapy is not a treatment for high-risk pancreatic anastomosis. It's a treatment protocol for PDAC. So, no, for resectable periampullary, I don't think that there is any role of giving radiotherapy to decrease the chance of POPF. It's a by default observation which has been made that in patients where radiotherapy has been given, the pancreas becomes more fibrotic and therefore the PJ becomes easier. Also, radiotherapy is a local treatment, it's not a systemic treatment. Let us first assume, I think we must assume this, that pancreas cancer and a good part of periampullary cancers are systemic diseases. If we are talking about that, radiotherapy by default becomes selective. I don't think in that case it makes sense to give radiotherapy for periamp or even for PDAC if there is no tumor related indication per se.
And students, it is never neoadjuvant radiotherapy alone. It is either neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy. And though those trials which have used chemoradiotherapy, the intent was not to decrease POPF. It was a byproduct that because radiation causes fibrosis, decreased enzymatic secretion, that is why the anastomosis becomes technically easy, chances of leak are less. So it's a byproduct. It is not the intent. Last question, Diksha, is from Dr. Gonesh Hada. Uh, what is the status of targeted therapy and immune checkpoint inhibitors?
Still a case in clinical research. I think this angle is progressing and may become stronger in very select group of patients where the molecular biology will allow for an actionable or a target to be identified. Apart from that, not in routine cases.
So today, when you do a PD and you send the specimen for histopathology, do you ask for any special immunohistochemistry or any genetic marker tests as a routine?
So I think that's more of an institutional thing. I think most centers will not, but high volume centers will ask for MSI and MMR and BRCA and the other mutations. But I don't think that all centers ask for that still.
So it's not the standard that you have to do it.
Yeah.
Okay, so that's what students you should say again, that it is only the routine histopathology and the pathological markers like as I mentioned earlier, the grade, the lymphovascular invasion, perineural invasion, in the lymph nodes, pericapsular invasion, and there are these new concepts of tumor budding and one more parameter, which would indicate which would be an indication for chemotherapy, even if otherwise there is no indication. So a poor biology, poor histology may become an indication for chemotherapy. The genetic testing is not a standard requirement like in breast or like in stomach or like in colorectal, but you may do it. But at the moment, as of today, it's not the standard of care. And same holds true about the immune checkpoint inhibitors.
But I also feel that this decision needs to be tailor-made depending on what is the kind of patient that is sitting across you. So physiological status, the educational capability of the patient, and whether they are affording for anything or not will determine whether we want to do this or not do this. I think these are very important parameters which we never talk about when we talk about science in surgery. But it's very important to identify what the patient is seeking from you. More and more patients now in your private clinic will come and ask you for molecular tests and genetic markers. So I don't think
So,
there is a place of saying no to them.
yeah, that's for the clinical practice, but for the exam,
Right,
I
sir.
think it is that it is not a standard practice.
Yes, sir. Right. Agreed.
Okay. Anand, anything else before we close?
No, sir.
Thank you, Diksha. Thank you very much for joining us again.
Thank you,
And
sir. Thank you so much for
hope
having
to
me.
see you as and when you are available. Please indicate to Anand your convenient date and topic. We will be very happy to have you.
Thank you, sir. Thank you, sir. Have a great day.
Thank
Thank
you.
you,
Thank
everyone,
you.
for attending. Thank you.
Okay, we will close.